Welcome to Pediatric Podcast for PedsCases.com.
Welcome back. In the previous video, we talked about the importance of family history as well as how to construct a pedigree. We drew a pedigree for our patient, Billy, based on a family history taken from his mother. In this video, we'll review the classic patterns of Mendelian inheritance and see how these patterns might look in a pedigree. We'll introduce you to several mini cases as practice before going back to Billy's case.
Now that we have constructed Billy's pedigree, we must begin to make sense of it in a genetics context. Does the underlying disorder truly seem to be inherited? What mode of inheritance do we suspect? What kind of diagnostic testing does the family history prompt? Furthermore, what are the implications for Billy's other family members? Is his younger sister likely to develop symptoms? How likely are his parents to have another child with a disorder like Billy? To demonstrate the utility of pedigrees in genetic problem solving, we'd like to discuss some of the basics of inheritance. In normal inheritance, each parent contributes a haploid gamete, which has 23 chromosomes, resulting in a child who has 46 chromosomes in total, or 23 pairs. There are 44 non-sex chromosomes, which we refer to as autosomes, and 2 sex chromosomes, which are the X and Y chromosomes. When we consider inheritance of genes located on autosomes, we think of each person as having 2 copies of each gene, one from their mother and one from their father. Each version of a gene is called an allele. If both alleles are the same, we call this homozygous, and if there are 2 different alleles, this is called heterozygous. Individuals who are genetically female possess 2 copies of the X chromosome, while those who are genetically male have 1 X chromosome and 1 Y chromosome. So for the 2 sex chromosomes, mothers always contribute an X, while the father can contribute either an X or a Y. This has implications in the presentation of X-linked disorders, which we will talk about later.
In autosomal dominant inheritance, we're talking about the inheritance of an allele of which 1 copy is sufficient to produce a particular observable trait, which we call a phenotype. Let's illustrate with an example. Let's say that the purple allele of the gene of interest is dominant and causes a genetic condition. In this case, the mother possesses the dominant purple allele and is affected by the genetic condition. The father has no purple alleles, so he is unaffected. Based on the law of segregation, half of the mother's gametes will possess the dominant purple allele, while the other half will possess the blue allele. The father has 2 copies of the blue allele, which means that all of his gametes will have the blue allele. When their gametes are combined to conceive a child, there are 2 possible combinations. A child will either receive 2 blue alleles, or they will have 1 blue allele and 1 purple allele. These scenarios are equally likely. Again, a child will be affected if they have 1 purple allele. Hence, every time this couple conceives a child, there is a 50% chance that this child will have the autosomal dominant condition. In autosomal dominant genetic conditions, either parent can transmit the trait, and male and female offspring are affected at the same rate. We tend to see the phenotype appear in every generation. There's a few notable exceptions to this general rule. An isolated case of an autosomal disorder can occur due to a new mutation in a germ cell, a de novo mutation. A de novo mutation can then be passed down to offspring, or if the mutation is associated with reduced reproductive fitness, we may only see this single case. Additionally, genetic changes are occasionally inherited, but ultimately not expressed. We refer to this as incomplete penetrance. Penetrance is defined as the proportion of individuals with a particular genotype who express the phenotype. For example, if an allele causing an autosomal dominant disorder is said to have 80% penetrance, 80% of individuals with that allele will show signs of the disorder, while the remaining 20% will not. This is important to note in pedigrees because sometimes an individual who appears unaffected is actually carrying a disease-causing mutation and thus has the potential to pass it down. Variable expressivity is also common in autosomal dominant disorders. This means that individuals of the same genotype do not necessarily have the same phenotype. A condition can be associated with a long list of possible features, and each affected individual won't have every single one. In gonadal mosaicism, some of a person's gametes possess a mutation that may not be present in other tissues of the body. This can happen if a mutation occurs in a germ cell that continues to divide, so some of that individual's gametes will possess the mutated gene while others will not. As such, the individual is typically unaffected but may go on to have one or more affected offspring.
In autosomal recessive inheritance, 2 copies of an allele are required to produce a particular phenotype. In other words, if the recessive allele is associated with a condition, an individual has to receive 1 copy of the recessive allele from each parent in order to be affected by the condition. In this example, the pathogenic red allele is recessive. The mother and father are carriers because they possess 1 copy of the recessive allele. So while they aren't affected by the condition, they carry those alleles and have the potential to conceive children who will go on to have the condition. Their gametes can be combined to produce children with 3 unique genotypes. There is a 25% chance that their child will possess 2 copies of the non-pathogenic green allele, in which case the child is neither affected nor are they a carrier of the red allele. There is a 50% chance that the child will have 1 copy of the green allele and 1 copy of the red allele. This is because there are 2 combinations that result in this genotype. Either the father contributes his green allele and the mother contributes her red allele, or vice versa. The end result is the same. There is a 25% chance that their child will receive 2 copies of the pathogenic recessive red allele, which means that they will be affected. In autosomal recessive genetic conditions, children who are affected typically have unaffected carrier parents. Affected individuals also often go on to have unaffected offspring. An affected individual can only have affected children if their partner is a carrier. The risk of inheriting an autosomal recessive disorder increases when one's parents are in a consanguineous relationship. Members of certain ethnic groups can also be at greater risk for some recessive disorders by virtue of the recessive allele being more prevalent in their gene pool as compared to the general population. Common autosomal recessive conditions with high carrier rates can result in a higher prevalence for this condition than we might expect based on the mode of inheritance. In this case, the pattern of affected individuals in a family may mimic the inheritance of an autosomal dominant condition. This is called pseudodominance. This occurs when an affected person has a child with a carrier of the autosomal recessive condition. Another notable exception to these general rules is that of uniparental disomy. In uniparental disomy, an individual receives 2 copies of a chromosome from the same parent instead of 1 copy from each parent due to errors in segregation. In this situation, a carrier parent can have an affected child by passing down 2 copies of the deleterious recessive allele.
X-linked disorders arise from genes on the X chromosome. If a disorder is X-linked recessive, it'll only appear in a female if she has 2 copies of it. However, because males have only 1 X chromosome, they will always express the trait associated with a recessive X-linked allele, despite only having 1 copy of the gene. In the example on this slide, the pathogenic white allele is located on the X chromosome and is inherited in a recessive fashion. The mother is a carrier, while the father is unaffected. Their gametes can be combined to produce 4 unique genotypes, as outlined on the slide. If they have a boy, there's a 50% chance that he is affected. If they have a girl, there's a 50% chance that she's a carrier. X-linked recessive genetic disorders predominantly affect males. Females can be carriers of this disorder, but their second X chromosome, which is normal, means that they are generally unaffected. If an affected male has a son, he must contribute a Y chromosome. As such, there is no father-to-son transmission. If an affected male has a daughter, he must contribute an X chromosome, which has a copy of the recessive allele, so his daughter will be a carrier. Exceptions to expression in females can occur if there is skewed X inactivation, where one of the 2 X chromosomes is inactivated more than the other, or in Turner syndrome, where 1 X chromosome is absent.
X-linked dominant inheritance is an uncommon pattern in which the phenotype associated with the allele is expressed in heterozygotes. So in this case, in contrast to the X-linked recessive pattern, a female with just one copy of the allele will be affected. As such, each child of an affected mother has a 50% chance of inheriting the trait, regardless of the sex of the child. It is important to note that some X-linked dominant conditions, such as Rett syndrome, cause male lethality, which will lead to an apparent absence of affected males. However, just like with X-linked recessive inheritance, affected males cannot produce affected sons. All daughters of affected males will be affected.
Next, we'll go through some simplified examples of different types of inheritance using sample cases of real genetic disorders. These cases will be less complex than a pedigree you might see in practice. In real life, patterns of inheritance can be masked and complicated by things like de novo mutations, expressivity and penetrance, and gonadal mosaicism. In addition, patients may not always know the full medical history of their extended family members, nor even know what details would be important to tell us. As we go through the cases, feel free to pause the video and answer the questions yourself before we discuss the answers together.
For the first case, we have a 3-year-old boy named David presenting with severe recurrent bacterial infections beginning when he was 6 months old. When a family history is taken from his mother, she states that no one else in the family has experienced anything like this except for her brother. Her brother, David's uncle, suffered from frequent and severe infections throughout his childhood and died of bacterial pneumonia at age 8. Once we have gathered all the information we need about her and her son's family, we can begin to construct a pedigree, looking at susceptibility to bacterial infections as our trait of interest. Now that we have our pedigree, what kinds of patterns are there? First, we can see that the only affected people are both male, indicating that this could be an X-linked condition. Both affected males have unaffected parents, making it unlikely to be a dominant trait. So, based on this pedigree, we would be suspicious that David has an X-linked recessive condition. This case was based on X-linked agammaglobulinemia, which is an immune deficiency that affects males and prevents B-cell maturation, resulting in susceptibility to bacterial infection. Other X-linked recessive conditions that you might encounter include red-green color blindness, hemophilia, and Duchenne's muscular dystrophy.
In the next case, you're meeting a 10-year-old boy named Sam, accompanied by his mother. Sam has sustained 3 fractures on separate occasions within the past year. Most recently, he was witnessed tripping during school recess, which resulted in a fracture to his right femur. There's no suspicion of child abuse. On family history, you find out that Sam's grandfather had fractured his legs multiple times when he was younger, but hadn't broken a bone since he was 15. His mother recalls that she and her brother, Sam's uncle, both had multiple fractures in their childhood while playing sports or during normal activities. The patient has a 16-year-old sister who has never broken a bone. From this information, we'll draw out a pedigree using frequent fractures as our trait of interest. Now, looking at this pedigree, what kind of patterns can we see? Right away, we can see that there are several family members with this trait. Since it looks like males and females are both affected at similar rates, and that the trait can be passed on by a male or female parent, it's likely not going to be an X-linked pattern. We can also see that there are affected people in each generation, and that there is no time when an affected offspring has an unaffected parent, increasing the likelihood that this is a dominant trait. From the pedigree, Sam's frequent fractures appear to be inherited in an autosomal dominant pattern. This case is based on osteogenesis imperfecta type 1, which is often inherited in an autosomal dominant pattern. This condition affects collagen, and in type 1 osteogenesis imperfecta, frequent fractures are a common presentation. Other autosomal dominant conditions that you might encounter include neurofibromatosis type 1, Huntington's disease, and Marfan syndrome.
Next, we have Jane, who is a 1-year-old girl brought into clinic by her parents, who are concerned that she seems to have frequent respiratory illnesses during which she becomes very sick. They also note that her stool is often pale and loose. They recently immigrated to Canada, so aren't certain what kind of screening tests Jane had as a newborn. On physical exam, Jane appears small for her age, and there are wheezes bilaterally on auscultation of her lung fields. She also coughs several times during the exam. On family history, you discover that Jane's family are all healthy. Jane has an older sister who is also healthy. On Jane's pedigree, we can see that there are no affected relatives, so her condition could be sporadic. However, given the clinical features of her condition and the fact that the pedigree indicates that it is not a dominant or X-linked condition, we would be highly suspicious of cystic fibrosis. Autosomal recessive conditions often appear as an isolated case, as carriers would generally not be symptomatic, and it is statistically unlikely for two carriers of a rare disease to meet and reproduce unless there is consanguinity. If we diagnose Jane with an autosomal recessive condition, we would determine that her parents are both likely asymptomatic carriers of the disease, meaning that there is a 25% risk of any of their future children also inheriting the disease. This case is based on cystic fibrosis, which is caused by mutations to both copies of a gene for a membrane protein called CFTR. There are a wide range of manifestations, including frequent lung infections, pancreatic insufficiency, and infertility in males. Carriers with only one mutated copy of the gene, like Jane's parents, are healthy, and the carrier frequency in the general population is relatively high. Other autosomal recessive conditions you might see include sickle cell anemia, hemophilia, and Tay-Sachs disease.
Last, you're seeing a 2-year-old girl, Gloria, in clinic due to her parents' concern that she appears bow-legged. She started walking somewhat late at 18 months, as she seemed reluctant to stand up and bear weight. Now that she has been walking, her legs have become increasingly bowed. On family history, you find that bowed legs run in the family. Gloria's father is bow-legged, as is his mother. He recalls that his mother, Gloria's paternal grandmother, mentioned that her father and all of her sisters were bow-legged as well. You draw out the following pedigree. There are several things that we immediately notice in Gloria's pedigree. The trait we are investigating appears in every single generation, which points us towards a dominant condition. An autosomal dominant disorder should affect males and females in the same ratio. In an X-linked dominant condition, we expect half of the children of an affected mother to have the condition, but an affected male will only have affected daughters and no affected sons. This pedigree is therefore a convincing illustration of X-linked dominant inheritance. The affected male in generation 1 goes on to have only affected daughters, as he obligately transmits the X chromosome with a pathogenic allele to them. His sons, however, receive a Y chromosome from him and an X chromosome from their unaffected mother, so they are unaffected. Conversely, half of the children of an affected female are affected. Gloria's paternal grandmother has 2 sons, one of whom is affected. Gloria's father will go on to produce only affected daughters. After your initial round of investigations, you find that Gloria's serum phosphate levels are low, while her urinary phosphate excretion is high. This is in line with hypophosphatemic rickets, which is an X-linked dominant disorder. Other examples of X-linked dominant disorders that you might encounter include Rett syndrome and Fragile X. Rett syndrome is lethal to males in utero.
Now that we have had some practice interpreting modes of inheritance and pedigrees, let's go back to our initial patient, Billy, to assess the pedigree we constructed in the previous video. We'll start by describing any obvious patterns and findings that we can see. Symptoms related to Billy's presentation, like pes cavus, gait abnormalities, and muscle issues, seem to be present mostly in his mother's side of the family. We can see pes cavus in one paternal aunt, but knowing that this case is isolated and that high arches are a relatively common trait, we are still going to focus on the maternal side for Billy's condition. In Billy's mother's family, males and females appear to be equally affected. All affected people also had an affected parent, and there is at least one affected person per generation. There is no consanguinity. Now, we can work through which modes of inheritance are likely based on these patterns. If the disorder was autosomal recessive, we likely wouldn't see so many affected individuals. We would also expect to see cases where someone with the trait has unaffected parents who are carriers. If the disorder was X-linked recessive, we would see more males than females being affected, and Billy's mother would be unaffected, unless we ran into the unlikely situation that her own mother was a carrier. If the disorder was X-linked dominant, we wouldn't see any transmission from father to son, which we can see between Ulrich and Brock. Based on Billy's symptoms and this family history, we would want to test for Charcot-Marie tooth disease. Based on our pedigree, it seems likely to be the autosomal dominant variant.
Knowing that this is autosomal dominant can also guide testing and treatment for Billy's other family members. Any siblings of Billy would have a 50% chance of inheriting this condition as well, which has implications for Sarah's current pregnancy. Likewise, if Ainsley and Brock are diagnosed, their children would also have these same probabilities. Although the hemophilia B in Billy's father's family does not seem to be related to Billy's symptoms, we can look at patterns here as well. Since both affected family members are male, we are initially suspicious of an X-linked condition. There are affected people with unaffected parents, indicating that it is unlikely to be a dominant trait. These patterns verify our knowledge that hemophilia is inherited in an X-linked recessive pattern. Billy's grandmother was likely a carrier, and her daughter Marion has a 50% chance of being a carrier as well. Billy's father is unaffected and cannot be a carrier, so cannot pass on this gene to his children. Remember that males cannot be a carrier of an X-linked recessive gene, as if they have only one copy of the allele on their X chromosome, they will display the phenotype. This pattern of inheritance could indicate the need for carrier testing for Marion and testing for any of her children.
Billy was diagnosed with Charcot-Marie tooth disease following assessment by a neurologist, nerve conduction studies, and CMT genetic testing using a blood sample. He demonstrated markedly slowed nerve conduction velocity, and he was found to have a mutation in the CMT1A gene, which is located on chromosome 17. Charcot-Marie tooth disease encompasses a group of genetically heterogeneous disorders which have a common clinical phenotype involving motor and sensory neuropathy. It is caused by mutations in genes that encode different proteins, which are present in various locations like in myelin, Schwann cells, and axons. More than 80 different genes have been found to be implicated in CMT. All Mendelian inheritance modes have been described for this disease, with autosomal dominant transmission being most common. The CMT phenotype arises due to axonal degeneration, resulting in distal muscle wasting, weakness, and sensory loss. Symptoms generally appear in the first 2 decades of life with a slow progression over the years. The CMT1A variant, which Billy has, is associated with a phenotype which is relatively benign compared to other subtypes. Patients usually remain ambulatory throughout their life. CMT1A also shows variable expressivity within families, with disease severity differing even between monozygotic twins. This explains the range of symptoms present in the affected family members on Billy's maternal side.
Treatment for CMT should address symptoms such as muscle weakness, balance and mobility impairment, and sensory symptoms, and therefore involves management by a multidisciplinary team. Billy and his family were referred to a genetic counseling program and a support group. Billy also began working with the multidisciplinary clinic to access physiotherapy, occupational therapy, and receive appropriate orthotics. Thank you for listening to part 2 of our video. We hope that you now have an understanding of Mendelian patterns of inheritance and the way that they appear in pedigrees. Thank you again to Dr. Blakley for her guidance in creating this set of videos.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes Store, share with your friends and colleagues, or think about getting involved.